I'm Dr. Joseph Abinasser, specialist oral surgeon, implantologist. Today I'm gonna talk about the SGS system, an overview from the P1 to P5D. I think all here we know the system very well, and all from the P1 to the P5D. First of all, when we choose our implant, or the system even, we look forward some factors, we look for the primary stability for the implant and the insertion torque, the implant geometry itself, and the stress concentration around the implant. Some articles talks about the optimal primary stability and the stress concentration are the combined result about mechanical and biological factors. Also, all we know that primary stability is influenced by the quality and the quantity of the trabecular bone, the implant geometry, and the thickness of the cortical bone. So, if we're going to choose an implant, we will look for the implant geometry, but for sure we have to look for the stress concentration around this implant. We have to know what is the bone reaction around this implant. This is a P1. We have an X-ray 3 years post-op, a very good marginal bone level around the implant. I love this implant. And we have the P7, the aggressive implant. This is a case with the external sinus lift with an X-ray check after 5 years. And the marginal bone level around the implant, it's very good. Even with the P5D, all is going well, even in the mandible. But sometimes it's not going well. What is happening? What is the problem? These two implants are same, P5D, SGS, and the lower mandible. What happened here? You can tell me. There is a early marginal bone loss around the implant. Why? We didn't load the implant yet. It's only on the second stage. I discovered this. The difference between these implants is the surgical protocol. Drilling protocol. We call it drilling protocol, surgical protocol, whatever you need to call it. So, when we talk about early marginal bone loss around the implant, we have to consider the insertion depth of the implant, the insertion torque, and the implant geometry for sure, surgical procedure and drilling protocol, bone density, switching platform, and so on. For today, I'm going to talk only for the first 3 points, okay? Some articles talks about the implant depth. When we are below 1.5 millimeter, we have slightly resorption of the bone. And so now, after 15 months, we have a gain of 0.7 to 1 millimeter. If we insert the implant subcrestally 1 millimeter below the crest, especially in the mandible. Why? I will show you after. So, this is how I work. This is a simple case. I only put the implant below the crest, maximum 1 millimeter. This is the first point that I'm talking about, to prevent, for sure, the early marginal bone loss. This is a case, simple case, also in the maxilla. Same, good result, everything is okay. Some articles talks about the insertion torque is related to the bone density and the implant geometry. For sure, that we all know that cylindrical implants has lower insertion torque than the tapered implants, and the tapered and the modified one. So for sure there is a big difference. As a result, we can see here the insertion torque of a cylindrical implant is lesser than the cylindrical tapered implant. And for sure, if we're gonna ask about the reverse torque, if we wanna remove the implant, that is also a big difference. Thanks. Okay. So in conclusion, in some articles we are talking about a linear relation between the bone density and the insertion torque and the reverse torque. It's very important this. So when we have a mandible case, we will have a higher insertion torque, a very high insertion torque, even with the all SGS system, especially with the P7. Okay. Now I will show some cases and I will show how I work with these cases. This is the drilling protocol from SGS company. I do not agree about it. Why? Let's say for the 3.5, we are putting P5D 3.5. The last drill for the hard bone, it is 3.2. Never do this. Do the full drill 3.2 and then we have to use something called the cortical drill. We have to use the cortical drill, maxillary and mandibulary. This is crazy for the maxillary, but believe me, you will have a good result. For the 4.2, the last drill for the hard bone, I forgot the soft bone. The hard bone, this is our nightmare. The mandible is our nightmare. The 4.2, they told us, do the 4.0 last drill. I do not agree. You have to also do a cortical drill, maxillary and in the mandible. So these are the SGS cortical drills. That is the red one for the 3.5.
Can you use the next drill, but just a little bit?
Yes, I will talk about it. Okay. So that is the blue one for the 3.5, the red one for the 3.5, the blue for the 375, the green for the 4.2, and the black one for the 4.5. So to get such good results, what I do is that, let's say for the 375 and the soft bone, the last drill will be 3.2, but I will do the cortical drill for the cortical part and the maxilla. If we are talking about soft bone. If we are talking about hard bone and the mandible, I will do the last drill 3.2 with the cortical drill, but I do not agree still now. What I'm doing now, I'm using the 3.7 that you said to me that. The 3.7, we can use it till 6 millimeter depths, till 8 millimeter depths, it's okay. It's okay, you will have an insertion torque about 25 to 30 Newton, which is great for us. Very good. This is a case in the mandible. Same protocol that I'm talking about. So, please do not exceed 50 Newton per centimeter. If you exceed it, and the implant still is not into the site the preparated site, remove the implant. Drill, use the cortical drill or the last drill 3.7, 6 to 8 millimeters, then insert the implant. You will be at 20 to 30 Newton. I'm talking about P7, P5D, P1, all. Another than SGS, any brand. So as we can see here, we can stop at 6 millimeter and then try to insert the implant. Or sometimes with D1 bone, I'm going to 8 millimeter. Some cases, honestly, I did full drill 3.7 to put a 3.75 implant at the D1. This is very crazy, but honestly, we are getting good results. Do not get over 15 Newton with any system you are using. I'm forgetting to use this one. Okay, so this is how I work. So we combined all the factors. Depth 1 millimeter below the crest. This is the day of surgery. This is the second stage. All is okay. This is a mandible case. Same. mandible case, we loaded. Still good result. Here. Till now, for me, it's okay because before I was getting a very high bone loss with this kind of implants. Even with other kind of implants, let's say Megagen, they have a big problem now. Okay, so for me this is good. Okay, I will show you some cases for 1 year after. Okay, so this is a case for a D4. It was a D4 bone. I did 2 under drills, but I still use the cortical drill in the crystal of the first 3 to 4 millimeters. You will get a good insertion torque, a good parameter stability, but you will get at the end a good result. Even in the D4 maxilla cases. Another case, mandible. So this is what I'm getting. Please, when you have bridges or 2 molars, splint the implants. Do not do single crowns. Splint the implants. And what I have to do, I have to say here, and you will get a good result in the mandible if we try to use this technique that I'm using. Even with the P5D, we can do an internal sinus lift. I elevate the sinus, I do the preparation, then I will do also cortical drill, 3 millimeter in the maxilla to get this result. Even don't afraid to lose this stability, this insertion torque. Don't be afraid. We are using some aggressive implants. They are aggressively very stable when we are putting these implants. Another case, it was a lower molar. I extract the molar and put a P5D. For sure, I grafted with the membrane and everything. But we all know in our clinic, some patient she came very early, barely 1 month and a half. I need to load it. We can't load this implant. I need to load this implant. I told her, okay, let's do it. So what I did the second stage after 1 month, 12 days. This is the second stage. We can see the bone in the distal root. Okay, we can see a black hole here. This is what? While I'm drilling, I go further 0.5 millimeter to 1 millimeter to have the chance to get deeper the implant below the crest 1 millimeter. So I count for this before putting the implant. But don't be afraid from this one. This one, it will heal after. I will show you in the x-rays. So this is the x-ray when we load the implant. Everything is okay. There is a bone maturation. And this one is after a few months. Till now, all is getting well. All is okay. Here, there is a big difference. There is a bone healing on this side and more bone maturation from the grafted socket. Okay, this is a case, simple case, mandible case. Same, I'm using the same drilling protocol that I like. And as we can see, it's an X-ray comparing after 1 year, almost 1 year, and still we're having a good result for the bone around the implant. And I think it will be okay for the future. Okay, this patient, I catch this patient yesterday. He came, these 3 implants, this one, I did a guided bone regeneration on this implant. We can see the difference, the texture of the bone on the last implant. This is a grafted implant. So, xenograft, all guided bone regeneration I do is xenograft. You can mix it with allograft, no problem. But allograft alone, it's a big question mark. There will be resorption. You will not see the bone after a few months. The allograft will resorb. If you mix it, it's okay. If you put xenograft, it's okay. But alone, never. Okay, so the last 2 PAs, if you can see. Okay, this is the grafted implant. Here we can see on the mesial there is a slightly bone loss, which is stable after so many months, we can see it here. And still with this all cases, I'm using the same drilling protocol. If I'm not using this drilling protocol, what will happen? I might have more bone resorption. And for sure, the implant will fail, or the implant will fail very soon. The last case. This is a case, one second upper premolar and one lower second premolar. Same technique. The second stage, all is okay. I loaded the implants. And then we catch the patient after more than 1 year, and everything's still good. I'm happy with the results. I'm really happy with the result. And I can tell you what I faced before with these kind of implants with other brands. Believe me, we have to do this. Don't go over 50 Newton. It's easy. Remove the implant, do the final drill. You will feel it in your hand. You will feel the stress in your hand. Okay? For a conclusion, for the depth of the implant placement, it will have to be, don't go further than 1 to 1.5 below the crest, subcrestally. Okay? Insertion torque, do not pass the 50 Newton. Keep it 20, 30, 25. Don't even be afraid to have 15. It's okay, no problem. Site preparation. Create your own site preparation. Create your own drilling protocol for any brand. And finally, the type of connection. Be sure that we have to use now the double connection. No more place for the X connection, the normal connection. Now the double connection is a revolution for our stability, for our bone stability around the implant. And that's it. Thank you so much. I'm ready for any question. قول الكويستشن على علي.
I work with the GD system.
Yes,
okay?
yes.
And I also have the same result with the bone resorption. And I know it's normal, but when I see the X-ray, I feel
Not safe.
Not safe, yes.
Okay. I used before the JD. JD is the same like the P7. You know the P7 from SGS? The external sinus lift to this is the same. It's the same geometry for the implant. So for sure the JD, you have to do the same what I'm doing. There is a clinic in Dubai that are putting him at JD, same. And even the JD, I think it has a bigger, higher insertion torque with the JD also. So release it from the crest. Don't be afraid. You will have a good primary stability from the from the lower part. Try it. Yes, very aggressive. Aggressive implants for me are used for extraction and immediate implantation. I'm not used for the D1 bone in the mandible. This is a nightmare. This is very bad.
There is limitation in your technique, because what you do when you have like 7 millimeters, you cannot go 1.5 millimeters more.
Okay, for the cases for when you have like 7 millimeter over the nerve, let's say. Okay, for sure I will drill not more than 7 millimeter. I have to be sure about that. So, but I will release the implant from the crest. So I will use the cortical drill, even at 7 millimeters. So the implant would hold with how many millimeter? 4. 4 millimeter, it's enough to have a good primary stability. No, don't be afraid. With short implants in the mandible, you will have a good primary stability. In the maxilla, if you have 7 millimeter, do an internal sinus lift. Don't go for 7 millimeter implants, and I will not elevate the sinus. No, elevate the sinus, put a... No, not bad. Wide ridge, okay, not bad. If you have a wide ridge, okay, let's say we will put an implant 4.5. Okay, so what I will do, the last drill will be 3.7, and I will continue only crystally till 4.5. So you will get the primary stability and the last 4 millimeters. أهلا بالحكيم. Welcome, you're welcome.
Can I take selfie with you?
Yeah.